All right. So the discussion is, of course, about neurofibromatosis and meningioma in that setting. I greatly appreciate the opportunity to have to speak with this group. I would like to point out that this is an unusual type of presentation for me because usually we don't talk about specific tumor types in great detail with neurofibromatosis. Instead, we speak about the syndrome in general. And so as I've been listening to this group speak, these are very excellent discussions so far. It's caused me to develop a sense of the need to modify the presentation in a sense that'll be on the fly. So what I really want to do is actually talk to you about neurofibromatosis type 2 and multiple schwannomatosis and the clinical issues that are associated with meningioma in those two subtypes. And fortunately, a number of you have already laid the groundwork for me regarding certain matters with respect to management and assessment of meningioma. And so it will, I think, be quite easy for me to move ahead with this. I definitely do not want to extend beyond the time limit. So let's get started. And I've mentioned that neurofibromatosis type 2 and multiple schwannomatosis, non-clinical schwannomatosis, are very rare disorders with an incidence of about 1 in 50,000. Neurofibromatosis type 1 is a very common disorder. 1 in 3,000 is the incidence in the general population, but it literally has next to nothing to do with this conversation. The incidence of meningioma and NF type 1 is roughly the same as the general population, perhaps a bit higher. So again, just to look at the pathophysiology to clarify this point, neurofibromatosis type 2 is a consequence of a mutation on chromosome 22. And this is one point in particular that I wish to really clarify, that we think of these as single gene disorders, but I want you to notice that this is a relatively small region on chromosome 22. However, there are dozens of different combinations or variants of the mutation in this region that will either produce the clinical condition NF type 2 or schwannomatosis. And these minor variations produce distinctly different clinical outcomes in this population. So what will relate all of these is the discussion about meningioma, but I think it's going to be important also to talk about Merlin, which is the primary mutated protein that is central to NF type 2. And I think that you will begin to see as we get toward the end of this, that this may be part of the connection with the best approach to analyzing the signal conduction problems associated with meningioma and schwannoma in this population. And I think that's what's most likely to lead us to targeted therapies which are effective and possibly even lead us to greater insights in the response to radiation therapy as well. Now, these are the classic clinical diagnostic features for NF type 2. It's bilateral eighth nerve tumors. This is an autosomal dominant disorder in 50% of the cases. 50% are spontaneous mutations occurring usually shortly after conception, fertilization, and you may also notice in this older classification system that one might diagnose NF type 2 with the presence of a single eighth nerve mass, together with a meningioma, glioma, schwannoma, or a sublenticular opacity. It's a form of cataract that's typical for this disorder. This is an older classification system that I wanted to put up because there will be a new classification system coming out within the next few weeks that redefines diagnostic criteria, in part because we have now the insights that are provided by DNA mutation analysis. So this has only been present for us over the past really about 10 to 15 years for diagnostic studies, and it's now beginning to make its way into meaningful genotype-phenotype correlations, which are helpful for us in the clinical setting, but more likely to be particularly helpful for us in the setting of developing targeted therapies. Now, you notice I mentioned only 60 to 70% of cases of NF type 2 will produce an NF2 mutation in assessment. However, that 30% which are not obvious bearers of an NF2 mutation are likely either mosaic distribution patients, or they are not NF2 cases. They are more likely schwannomatosis cases. We'll see that in just a moment. So the condition schwannomatosis, one might think about schwannomatosis in general as NF type 2, in which there is no disease above the craniocervical junction, with a few exceptions. We do have mutations that are well-defined for schwannomatosis. SMARCB1 or INI1 was the first to discover. LZTR1 has now been recently published. We published just about 10 years ago with a very large collaborative effort. And NF2 mosaic state, which is a sort of a mid embryonic developmental phase where the mutation occurred later down the line in the formation of the neural tube. And back to that notion of single gene, which often gives the notion that implies the notion that this is going to be a relatively simple topic and a great target to study and a great target to treat. There's actually nothing simple about it because they're not truly single gene mutations. Virtually every mutation that one could imagine, every type of mutation or alteration in the DNA may occur. And again, this is actually quite a broad region along chromosome 22. Now, I will tell you that in schwannomatosis and neurofibromatosis type 2, the mutations are essentially shoulder to shoulder, but a few base pairs may make all the difference in the world. And of course, NF type 2 is associated with intracranial meningioma. In particular, LZTR1 mutations that produce schwannomatosis are frequently associated with either a single isolated meningioma or acoustic schwannoma or other schwannomas within the cranial vault. So, looking at the questions of cell signaling and this very nice review that was put out just fairly recently in 2020, this is related to meningioma specifically. This data comes from meningioma, and I wanted to bring out some particularly interesting issues that will overlap with the clinical discussions that we're going to get into a little bit later. But EGFR mutations are quite common. P10 mutations are quite common. Methylation mutations are quite common. Relatively rare are targets that were presumed to be hot topics in evaluation of schwannoma and meningioma and NF type 2, but relatively rare. Higher grade meningiomas evidently will express checkpoint inhibitor checkpoint mutations in about 25% of the cases, but these are not noted in the lower grade meningiomas. And mentioned in this paper, therapeutics directed toward NF type 2 could be considered for treatment of meningioma. And we're going to look at that question specifically as we move along here. So this was already covered very nicely by Dr. Ballister. So this is the old classification system for meningioma grade 1, 2, and 3, and it's only a value here at this point for the recognition of the fact that these more aggressive tumors that occur in the setting of NF type 2 are frequently quite lethal, especially under other certain conditions. A 10-year survival rate of 33% for irradiated meningioma in grade 3, I think is a reasonable reflection, but this all depends on location. Now, we're back to that slide. I'm going to repeat it, but skip it now and show you the general map and sites of cell signaling. This represents a relatively comprehensive picture of the signaling pathways in the cell. And sites of interest for NF type 2 include growth factors, chemokines, sites for apoptosis, which are defective. Sonic hedgehog finds its way into this story, as does Wnt and smoothen. So targets in particular that we'll be looking at a little more closely here in just a minute, and I'm going to run out of time soon, I know, but the family of mitogen kinases, including ERK, the role of AKT in negative feedback, and the role of RAS in particular are quite important in this condition. So if we look at the signaling pathways in general, we're all fairly familiar with the idea of the use of Avastin and similar products for EGFR or VEGF inhibitors for management of acoustic schwannoma. Now, typically in most of the work that looks at volumetric changes in these tumors that appear to respond to VEGF inhibitors, what we find is that the degree of tumor reduction in NF type 2 is on the order of 10 to 20% volume at most. Hearing in the acoustic schwannoma patients improves for a period of usually 6 to 9 months before it then regresses and becomes resistant to the treatment. And no one's really looked all that extensively at the fact that the tumors then continue to grow afterward. The role of VEGF inhibitor in meningioma management has been even less impressive. But these are the targets that people are beginning to look at. The MEK inhibitors I mentioned, I'm going to tell you about one in a minute. The rapalogs in particular, not only rapamycin, but everolimus is one of the agents that's being used in a number of trials for meningioma management and NF2. And AKT inhibitors. So the pathophysiology of a schwannoma is thought to be contact inhibition, loss of contact inhibition in the Schwann cell. And of course, Merlin is the protein that is mutated primarily as the signature of NF type 2. So one must ask oneself, where do all these meningiomas come from? Well, probably 50 to 60% of the meningiomas that we find in NF type 2 will reveal an NF2 mutation, but oddly, not all of them do. And that was discovered in a trial where for a smoothen gene inhibitor, where enrollment into the trial required presence of an NF2 mutation within tissue assessed from resected meningioma. And only about a third of those actually revealed a mutation in chromosome 22 to indicate an NF2 mutation. So the pathophysiology is not clear at all, as is the pathophysiology of schwannomatosis, where meningiomas also occur. Now, just a few clinical pictures quickly, and I think you'll see the overlap with some of the other speakers. This is an NF2 patient with grossly problematic bilateral acoustic schwannomas, but right here is the meningioma, right at the foramen magnum, making this situation even more complicated than it appears in this situation. Here it is after radiation therapy with radiation that necrosis seen in the sites of the acoustic schwannomas. This is several years afterward, and you'll notice that meningiomas have developed in multiple other sites, literally spread throughout, often indistinguishable from the schwannomas that are associated with NF type 2. And here is, I think, a very important set of images. So I'm going to follow right along with these in just a moment. But this is a patient with NF2 after radiation for bilateral acoustic schwannomas, multiple small schwannomas that you see here, and perhaps, meningiomas that you see here, as well as cavernous sinus meningioma. And in the base of the skull, this entire region was biopsied and found to be tissue consistent with meningioma. Now, spine is an equally important problem for us, and this is the residuum after a resection of a cervical schwannoma intruding into the spinal space, as well as multiple small regions of meningioma. Again, here's another view of the NF type 2 meningioma developing on the cavernous sinuses. And I would like you to notice also meningiomatosis and schwannomatosis developing all around the lower aspects below the palate, creating a lot of the complications that we have in our patients with NF2. And here's a very interesting situation. This was described, I think, also by our pathologist, which is the sheeting patterns that might be seen in diffuse schwannomatosis, diffuse meningiomatosis. And here we've got a nodular meningioma in association with plaque-like meningiomas extending on either side of the septum, and in association with that is a large meningioma that developed later in the midline, as well as meningiomatosis and a plaque-like distribution along the sagittal sinus. Now, on some occasions, this will actually occlude the sinus. On other occasions, it will simply coat the sinus, and we think that most likely that the arachnoid granulations are obstructed by the presence of the meningiomatosis, the plaque-like meningiomatosis there. But in either case, it can lead to hydrocephalus or certainly intracranial hypertension and extraordinarily severe headache syndromes, as well as visual problems. And here is another example of that. You can see this patient's been shunted. This sinus is actually thrombosed. And then you can see the intraventricular meningioma that's growing here. This is a different patient than the one we just showed you a minute ago. So meningioma can develop just about anywhere within this system. Intracranial meningioma and spinal meningioma, and it's rather like playing whack-a-mole trying to chase these. And usually either surgical intervention if possible or radiation, as you just heard about, will be our options for managing these patients. But of course, this represents a systemic disorder of this nature, represents the need for a systemic therapy. And of course, targeted therapies are of interest to us. And I just wanted to quickly point out one, which is Merlin, which is the central protein previously thought to be simply related to contact inhibition and feedback signal for Schwann cells, has come under investigation extensively. And now it's recognized that there are activation and feedback loops in association between Merlin and a whole host of other cell signaling molecules, including YAP, ERK, as we described in a minute, and AKT. I think another important point here is P53 I want to point out, because something that's not recognized very often in thinking about NF type 2 is the fact that malignant transformations do occur if that individual is unfortunate enough to not only carry an NF type 2 mutation or a schwannomatosis mutation, but if they're unfortunate enough also to either generate or to be born with a oncogenic tumor suppressor gene mutation such as P53. We have 2 cases of intracranial meningioma of grade 3 within the setting of NF type 2, and that was spontaneous. We have in that same child, who's a teenager, she also then went on to develop sarcomatous change in one kidney. And it seems very unlikely that the NF2 mutation was the driver gene in that case. It seems much more likely that the driver gene was her P53 mutation. So the point is, Merlin, I think the story of Merlin is just beginning to open to us as we begin to understand it and its relationship with a great number of other signaling molecules. Now, I want to quickly get to a targeted therapy that I think is going to be important, because I think it's quite promising. I discussed Avastin with you a minute ago. Not clear from over 10 years of data that it is a particularly useful, durable effect, will have a particularly durable effect. However, there are 2 quite interesting drugs. The first, mostly for a theoretical point of view, and that is the use of heat shock protein inhibitors in combination with curcumin. Now, one of the problems with this is that curcumin is not absorbed adequately to provide central nervous system levels to be effective, and heat shock protein inhibitors are generally so toxic that they're intolerable. The reason I brought this up is because about 15 years ago, we were able to culture some cells of Schwann cells and meningioma cells from an NF2 patient. And we were pursuing this particular protocol because the individual I was working with had developed a form of pegylated curcumin, which is absorbed to a vastly greater extent than oral curcumin. That went the way of patents that will never be achieved and drugs that will never be reproduced, but it was quite possible to terminate cells in culture very, very quickly. Unfortunately, not with an agent that is tolerable to most humans. Now, we attempted to replicate this by substituting bortezomib, which has been suggested in the literature as a very, very promising agent to treat schwannoma and meningioma in NF type 2. And the best I can tell you is that we've managed to treat a few patients off schedule with this and had no positive results at all, despite what it will tell you in the literature. Now, quickly, I want to move to one very, very promising targeted therapy, and that's brigatinib. So brigatinib is the tyrosine kinase inhibitor, active across many different signaling molecules. So ALK, insulin-like growth factor 1, and EGFR as well. Interesting, it does inhibit ALK phosphorylation. This was determined primarily by Scott Plotkin and others at Harvard by looking at animal models. And again, this will tell us a murine model of NF2, a knockout model. The brigatinib had a very significant effect, a very profound effect on all tumor types, not just the schwannomas, but also the meningiomas, and the third tumor type that afflicts NF2 patients, which is benign ependymoma or tenocytic ependymoma. Now, I did it without major toxicity. One problem with this so far is that, as we're all aware, that knockout models, engineered mice, represent a very homogeneous population. And remember, I pointed out to you that there are a vast number of different mutations within a very small coding region on chromosome 22 that will produce either NF type 2 or schwannomatosis. So it's very promising. If you wish to pursue this, here's the reference talking about this. And interestingly, inhibition of ALK was not one of the pathways that was discovered as important in the efficacy of this targeted therapy. But brigatinib, personally, I've had the opportunity to treat 3 different patients with this. How does one do this off schedule? Well, they happen to be children of military families. In the military, I suppose it's easier to treat people off schedule. And I now have 3 children treated with, or adolescents treated with brigatinib. And they have shown a minor degree of regression over an interval of 6 to 9 months, but more importantly, they have not shown rapid progression. And it may be ultimately that targeted therapy will buy us stasis of tumors rather than significant tumor mass regression, but that alone, used in a strategic fashion, could be extraordinarily beneficial to this population. So I will take you back through quickly the rapalogs, trials currently undergoing, including everolimus, so for mTOR inhibition. MEK inhibitors, which really, I guess we could put brigatinib in this category. VEGF inhibitors, less enthusiastic, but these, and HAK inhibitors, as we talked about with bortezomib and other agents, which are unfortunately in combination are excessively toxic. But these are our areas right now of promise, and particularly, I believe, of promise for this population will be brigatinib. So I'm going to stop at that point, and I think we're roughly on time.